So welcome everyone. Thank you for joining. We are holding the next webinar of the EANS ETIN task force, which is the task force on emerging technologies and innovations in neurosurgery. And today we are very pleased to talk about one of the emerging technologies in spine surgery, which is mostly augmented reality and also some other navigation methods. And for this, we are very pleased to welcome Professor Adrian Elmi-Terander, who is an associate professor of neurosurgery at Karolinska Institute in Stockholm, as well as the Capio Spine Center in Stockholm, and also holds very active research positions actually there with multiple PhD students focusing really on various different navigation methods in spine, mostly on augmented reality, where he really is a specialist. He trained also at Karolinska. He did a PhD in clinical research at Umeå University. And we are very pleased you will be talking about augmented reality, advances in spinal navigation, augmented reality, and optical methods. So to all of the people who turned into this webinar, please don't forget that there's the Q&A function. So during the webinar, if you come up with any questions, just please post them in the Q&A function down. And at the end, we will be able to discuss it with the entire panel. So without further ado, welcome, Adrian, and please take it away. We can't hear you, Adrian.
Can you hear me?
Yes, you are fine now. Yes.
Yeah. Thank you very much, Victor, and thank you, the organizing committee, for inviting me to this webinar. I'm going to talk about a topic that is that I like quite a lot, and I have spent many years in research, and I hope that it can be useful to you. When we are talking about augmented reality, I think the first thing that most of us think about is the Pokemons. But what is augmented reality? Augmented reality is superimposition of a virtual environment on the real world. In spine surgery, we are talking about superimposing mostly radiological information on the surgical field to enhance the experience of the surgeon. This can be used, done by either using preoperative or intraoperative imaging. And by using a computer-generated image, you can get a picture where basically you can see through the patient, as you can see on the image here on the right panel. So what does augmented reality add to surgical navigation? What's the difference between augmented reality navigation and regular navigation? Well, this is a valid question. You can use your anatomical landmarks or whatever other aids you have for navigation until you have a complicated case. When you have, for instance, something like this for revision, you can see that there is basically no anatomical landmarks, and you would be very happy to have any kind of help as far as you are not a Superman. But what augmented reality does basically is that it makes you Superman. It adds the capability to seeing things that you would not be able to see otherwise. The main additions of an augmented reality.
We are not hearing you, Adrian. Your microphone turned off. Yes, now it should be fine.
Yeah, am I back again? Okay.
Yep.
Sorry for this. The main thing that an augmented reality system it does is to add functionality to existing technology. Obviously, the augmentation is one part, you can even add segmentation, where interesting parts of the anatomy are defined and superimposed. An augmented reality system offers you the integration to optimize your workflow without losing line of sight, without needing to look at different places. You can concentrate on the surgery in the surgical field. And one of the most important features is the education part, when you can learn to do surgery much easier. You can use it in the OR live, and you can also use it via telementoring, where the senior can be basically anywhere in the world and aid another surgeon somewhere else. But when augmented reality systems emerged for about 10, 15 years ago, they were not so sophisticated. They could look like this. This is a picture from 2015, so it's not so many years ago. And when you look at the publication within this field, it started basically around 2015, 2016, and there were a few publications. And so it continued until 2020, when we basically had a complete explosion of articles in this field. And I just made a search on PubMed just a couple of days ago, and I found almost 300 papers on augmented reality in spine surgery. When we're talking about augmented reality, it is important to notice what interfaces are available. The current available interfaces are head-mounted displays, which I think is the future of this field. There are monitor displays. You can have projection, and you can have microscope augmented reality. When it comes to projection, you're going to basically project an image back onto the patient. It is quite accurate if you want to do a simple task, for instance, an interventional injection. But for surgery, when you are moving and changing your position, the projection will not follow. So that's not optimal. And the microscope navigation is obviously very good. It has been used quite a lot in intracranial surgery, but when it comes to spine surgery, before the stage you bring in the microscope, obviously it is of no help. The devices, they can be very expensive or very cheap. On the top left, you have a hybrid OR, which costs around 5 million euros. Then you have the X-Vision, and the bottom right, you have a HoloLens, which you probably can buy for the same price as a cell phone nowadays. Okay, how does it look? This is a demonstration of an augmented reality visualization during surgery. This is for placing of a pedicle screw. And as you can see, you can basically superimpose the spine onto the patient, and you can, using your instruments, see exactly where to go and how to direct your instruments. I am going to talk about 4 different interfaces regarding augmented reality. There are many more coming on the market, but these are somehow different systems that I think could be of interest. The first one is a surgical navigation based on the hybrid OR. This one was developed by Philips. The features of this system include a non-invasive patient tracking using only adhesive skin markers, which is superior to traditional navigation when you have to use a dynamic reference frame attached to a spinous process, because those frames are almost always in the way, and they can be dislodged and you will lose the accuracy. This system provides intraoperative cone beam CT, and the navigation and augmented reality part is performed using 4 cameras embedded in the C-arm detector. which you can see on the right panel here. I had the privilege of working with Philips and developing the system, and we did several studies. I can just briefly say that when we started, the accuracy was not so good, but while we proceeded and added functionality to the system, we could basically reach 100% accuracy in one of our last studies when we added a robotic arm to the system. Another system, which is the first FDA-approved system, is the X-Vision. Here you can see Dr. Molina using the system. This one is a head-mounted device when you can have the augmented reality images in front of you. As you can see, in this case, the augmented reality rendering is not very good, but this is dependent on what kind of radiological source you use. I think this is based on an O-arm, and you can't get better rendering than the images you have. Nonetheless, they have shown that the X-Vision received very good clinical accuracy, up to 99% on the Gernsbain system for placing pedicle screws. Another system which is used worldwide is the HoloLens. HoloLens is used often together with open source programming and a little bit of homemade systems. It is cheap, it is easy, and it provides relatively good accuracy. But as you can see, you have an accuracy which is 3 to 4 millimeters, and this is obviously not good enough for precision surgery. However, there are room for improvement, and the main challenge here is something that I will get back to, and that is patient tracking and registration. When you use any augmented reality system, you need to have a good alignment between the image that you want to overlay and the patient. And how you align these two systems is going to be crucial for the accuracy that you achieve. So the major challenges for augmented reality systems in future is to obtain a good patient tracking and registration, which is live and updated during the surgery. Obviously, the navigation interface is also important, and I think that the head-mounted displays will going to lead this part. And another issue is that you need to have a workflow that is compatible with surgery. You cannot stop and realign your systems every 5 minutes, because that will not be feasible at the end. Regarding patient tracking, most systems, as I told you, use different types of dynamic reference frames, but I think that the solution in the future would be to basically use the same feature that you have in your cell phones for face recognition and recognize the patient that way. We have done some studies when we have used either normal RGB cameras or hyperspectral cameras for identifying features on the spine in open surgery or on the skin in minimally invasive surgery. And using computational power, we could in that way constantly update.
Your microphone is off again, Adrian. Sorry.
So,
yep, you are back.
Back again. Good. As I said, we have performed some studies using different tracking features for open surgery and minimally invasive surgery, when either RGB or hyperspectral cameras have been used to identify features on the spine or on the skin to automatically realign the patient and the information during the surgery, despite moving or placing screws that results in movement of the patient. One of the interfaces that I have been working with is the Magic Leap, together with the BrainLab navigation system. And when you wear this and you use the navigation, you will feel like the the holodoc in the Star Trek. We published the first Phantom study when we showed that we could reach quite good accuracy, and it was feasible to use this system. Here you have a short video demonstrating that you can plan your trajectories and you can then adhere to them when you place your screws, in this case in the lumbar spine. The good thing about this is that you can basically visualize the trajectories where you have placed your screws, and you can align them so you can then place your rod without any difficulties. And if any screw is deviating from the planned path, you are going to immediately see that when you're looking at your patient. And when the Phantom study was finalized, we decided to do a cadaveric study, and that is because when you use phantoms, they are plastic, the tissue is not elastic, and obviously it can be a little bit misleading.
We lost you, Adrian, your microphone. No, can't
I'm
hear
not
you.
back?
Yes, now you're back. Now you're back.
Okay.
Yes.
Hello?
Yeah, it works. Can you hear us? No, now we are not hearing you again.
Am I back now?
Yes. Yes.
Can you hear me now? Okay, sorry for that. I don't know what's wrong with this. Okay, I was talking about going from phantom to cadaveric study, and that's because in this case a pig cadaver was used to do a minimally invasive screw placement, and that is because it gives a more realistic picture compared to using a plastic phantom. And we noticed that we could reach sub-millimeter accuracy with this device and 100% clinical accuracy. I'm going to show parts of a video if it happens to work. Yes. This is the initial phase when the specimen is draped, and I will fast forward in this video. This is the Loop X, which is a cone beam CT device by BrainLab. And when the images have been acquired, the surgeons will go on. In this case, reference frame is attached to the specimen because this is a hybrid system using augmented reality and conventional navigation. I go forward here to about 3 minutes within this video when here the surgeon is calibrating the system, and very soon you will see that he is going to use the augmented reality feature. And this is filmed through the glasses, and that is the view of the surgeon. So the spine is overlaid onto the specimen. The colored lines are the planned screws, and he can adhere to this, seeing the augmented reality on the patient and the 2D navigation images in front of him to perform the surgery. So what is the surgeon's experience? Well, this was very easy to learn and to use. It could be easily integrated into the sterile environment. It didn't interfere with the surgical steps. We had very good augmented reality rendering using this cone beam CT device, and you could get immediate feedback on the screw trajectory. And the funny thing is that my resident could basically perform this procedure faster than me after a few training rounds. And that is quite important because this kind of surgery can often require many years of experience, but using augmented reality, you can shorten that time. I have to say some words about robotics when we are talking about augmented reality, because robotics can be combined with augmented reality. There are many surgical robots on the market. And what is their share of this story? Well, obviously, they are more stable than the surgeon's hand. The trajectory is more reproducible. And if you are going to do long procedures with many screws placed, obviously a robot can be of an aid. The problem is that they are not increasing the accuracy extremely. If you start with an augmented reality system with 98-99% accuracy, the gain is quite small and the cost is considerable. So at this moment, I think you can do with your augmented reality system without a robot, but if you can afford a robot, obviously that is not a disadvantage. I will also say a few words about virtual reality in spine surgery. I think that virtual reality will be more and more used for preoperative planning, for anatomical education, and also for communication with your patients. The ability to perform simulated surgical procedures makes virtual reality an ideal educational tool. And there are many centers that offer virtual training for different surgical scenarios. And simulation by virtual reality in spine is endorsed by numerous organizations already. So in summary, virtual reality is immersing yourself in a completely artificial world. Augmented reality is overlaying a digital layer of information onto the environment, and mixed reality is a mix of augmented and virtual reality, and that is what we often use in real intraoperative navigation. So this part concludes what I was supposed to say about augmented and virtual reality. But when we are talking about other emerging techniques for surgical navigation, I will say a few words about optical methods to perform accurate surgery. Obviously, when you have an augmented reality system, even if you use the cheapest ones, requires some equipment and requires that you have at least an intraoperative imaging device. So sometimes if you are in a low resource setting, other options could be valuable. One of the options that my research group has been working on is to use diffuse reflectance spectroscopy to provide feedback during pedicle screw placement. Diffuse reflectance spectroscopy basically means that you are going to illuminate a tissue with light, and what is reflected is gathered, and each tissue has its own fingerprint. And then you can use machine learning algorithms to determine individual tissue components and use that to guide your instruments during the surgery. This is a recent study that I did in the Netherlands just a couple of months ago. And we could easily distinguish between different tissues, as you can see, because they have different spectral fingerprints. In a study that we performed on pedicle screw placement and using only the lipid volume fraction, we could see that we could identify the cancellous bone, the cortical bone, and an area that we defined as the precortical zone, which is just before you go from cancellous to cortical and before you cause a breach. By building in this optical device into a pedicle probe, for instance, you can easily feel when you are going through the different tissues and get the immediate feedback if you are in the cancellous bone or if you are approaching the cortical bone and if then a breach is imminent. We have now in later studies tried to build in several optical fibers looking in different directions, which will give the surgeon the possibility to guide this device and find the correct position for the pedicle screw. This is right now in the process of being built into a one handheld piece, a single-use handheld piece, which can be easily afforded with around 500 euros in costs, and could be a good viable option for those who cannot afford a costly navigation system. So how will the future look? Well, we are going to need good imaging to do good navigation, and especially augmented reality. There are several efforts going on to reconstruct good intraoperative images from, for instance, intraoperative fluoroscopy. And I think that this is a part that will make using augmented reality easier. The patient tracking needs to be live and not based on reference frames to allow a good alignment between the imaging data and the patient. Regarding tracking, we are going to use more inside out. In that manner, inside out means that you have the tracking in your head mounted device, for instance, instead of having a camera outside the surgical field looking at you. And in that way, you are going to minimize the line of sight disruption. The navigation interfaces, I think, going to be small head-mounted devices of low weight, and most probably they will add zooming features to them, so you can, in some cases, even skip the microscope and use the head-mounted device for the whole surgery. The accuracy can be improved by surgeon-supervised active robots. Right now, all the robots we have are passive, but I think that the future will give us more active robots. The radiation exposure needs to be minimized, and I think that the improvements in imaging will also provide the possibility to use less radiation, and I think that it is important the radiation to staff be almost zero. These things together will result in an optimized workflow, and I think that, for instance, spine surgery should preferably be performed in a hybrid OR when you can use different modalities to enhance and help you during the procedure. And one of the other features that is going to be needed for a smooth workflow is that all the instruments that you are used need to be tracked automatically as soon as you come inside the field of your vision using your head-mounted display. Yeah, I think that I will conclude with that. Thank you very much for listening, and thank you very much for inviting me. And I get the word back to Victor for the questions.
Thank you so much, Adrian, for your presentation. I think it was a really good overview of actually perfectly fitting in the EANS webinar of various different things, not only augmented reality. You also talked about robotics, even about like more Star Trek stuff like diffuse reflectance spectroscopy, hyperspectral imaging. So really nice. Thank you. Maybe I'll start off with one question, and then meanwhile, please, to all the participants, don't be shy to write questions into the Q&A section. We will look at them. So if I may first ask you a question, I think this is something that I have thought about when I look at your presentation, is we don't use here augmented reality for spine surgery, but if a participant, for example, wants to start using it, can you very practically take us through what equipment do you need and what is your workflow actually when you operate a patient? Let's say pedicle screw placement with augmented reality. Do you have to like export images? Do you have to make intraoperative images? How do you co-register? When do you put on the thing? Very practical stuff. Can you show us how to get started with it?
Yeah, well, it depends on what system you are using, basically. Oh,
you're just your microphone just turned off. Yes, I think you're back.
No?
Yes.
As I said, it depends on what system you are using. Different systems have different requirements, but most systems can use both preoperative and intraoperative images. When it comes to spine, most procedures are performed in the prone position, which means that an intraoperative image is more accurate because the preoperative images are obtained in the
your microphone is really shutting off. All right. Yes, I think you're back.
Yeah, this is highly annoying, but okay. As I said, the preoperative images are all often used, performed in the supine position, and you have the patient in the prone position. So an intraoperative image is more suitable. If I look at the systems that are available on the market right now, if you use the X-Vision, for instance, then you have to attach.
Adrian, I think you should invest in a new microphone next time. Yes, now you should be audible again. It's a virtual microphone.
Yeah. So now,
Yes.
now we shall see how many seconds we can talk.
We're hopeful. Okay.
Yeah. Yeah. Well, if you look at the X-Vision, they attach a reference frame to the patient, which is recognized by the system, and the overlay is automatically done by looking at two different references that do attach to the patient. If you look at the BrainLab system that I showed, it uses the normal dynamic reference frame that you have for navigation otherwise, and you just look at the QR code on the screen of the navigation system to align the images with the patient. So this is going to differ depending on what system you use, and the more sophisticated systems you have, the easier is the overlay. And if you use the cheapest one using, for instance, the HoloLens, then you have to basically manually overlay the image, and that will give you a much less accuracy.
Okay, thank you, Adrian. Can you maybe turn off your screen sharing so we can see you and see the board in full?
Yeah.
That would be nice.
I have a question, if you don't mind.
Yeah.
I still have the feeling that augmented reality does not give me this feeling of security that we have with neural navigation alone or with robotics. So what do I think on this point?
Could you please repeat the question? You think that it's not?
I don't have the feeling of security when dealing only with augmented reality or virtual reality. It's I don't feel really secure. Probably it's personal. Probably it's a question of evolution of technologies, but I feel much more secure with simple navigation or with navigation combination with circ or some other kind of robotics. So what do you think about this gap? Does it exist? Is it only my personal feeling or is something objective?
No, it is not. I think that this is a larger problem for us senior guys. We are not used so much to computer games, and I think that the younger generation, they are much more convenient with these systems. When I started using these systems 10 years ago, obviously it was a little bit inconvenient, but the good thing is that when you start using them and you notice that they are accurate, then you are starting to trust them. And
your microphone, Adrian. Yep, you're back.
20 procedures before you get used to this system and you can trust it. But as I mentioned before, I performed one of these experiments with one of my residents. But basically, after 10 minutes, he could do it as good as I could do. So I think it's a question of training, and it's a question of generations. The youngsters will be more convenient than we are.
Okay, any other questions from the board, I see?
Yes, this is just to compliment. First of all, Adrian, congratulations for a great talk. And to answer, to add on to the question which Nikolai asked, I think the difference between augmented reality and navigation is very little. With navigation, we are doing exactly the same, with the difference that this image is on a separate screen. So what we do when we use navigation, we have this attention shift. We have to stop our surgery, and then we have to look on the screen, see what the screen is showing, and then come back to the surgical field. So this attention shift now is kind of annihilated by having this augmented reality. With the benefit is that we are not expected to operate all the time under augmented reality. We are operating all in the normal kind of field, and only when necessary we can just click the button and this image is projected on the surgical field without us having to stop, look on the screen, get the pointer, and do the same. So this is the way I do it. I have this microscope-mediated augmented reality. Usually we operate without it, but if I need to have some coordination to know where is the deep vessel, where is the tumor, where is something important, I just quickly activate it. It projects everything. It is very reliable. And then it gives you this kind of reassurance about what is happening, and then you switch it off and carry on as normal. So, but yeah, it is about getting used to this, and I don't think it is insecure. It is trying to get used to something which is different to what we used before.
And to that, I really liked, Adrian, your way of how you presented augmented reality, not as a standalone technology, but basically as a way of visualizing navigation. So it's not really something different. It's visualizing or integrating more ergonomically the navigation that we already have. We cannot hear you. Yes, I think we can.
Try again.
Yeah.
Well, there are two issues. One is that exactly as you say, when you are using the microscope, you don't want to have it all the time in your field, because this is quite disturbing. Actually, it results in some inattentional blindness, because you all of a sudden, instead of you looking at the surgical field, try to look at different colors, and that could be actually quite disturbing. So being able to put it on and off is quite important. And another issue which is quite important is that obviously you have many years of experience. You can look at the 2D image and process it in your brain to the 3D. For the youngster who has just started his career, this process will take some time. So by giving them the augmented reality, we are going to shorten this learning time and processing time before you learn to go from 2D images to 3D.
Nicholas?
Yes, hello, thank you for your, I just want to ask if you are thinking about, or if you are doing already, other application beyond the pedicle screws. If you are using it, or if you are thinking about it, and which application do you think is more to be beneficial?
Well, thank you. Can you hear me, Victor, still, or am I am I out?
Very
Good.
nicely, yes.
Yeah. There are several other applications when this could be used. The reason that we have used it for pedicle screw placement primarily is because it's much easier to measure accuracy when you have bone. But I think that this could be interesting for tumor surgery. Before you open the dura, you would like to know what is the extent of my meningioma. Or if you do an intramedullary tumor, you would like to know, okay, where are the poles of this intramedullary ependymoma? And in that way, you can make a more accurate incision. So these are the fields when I think that this could have much more benefit for the experienced surgeons. And obviously, when you leave the spine, I have tried to develop the same system for the cranial surgery. We are now running a project to use it for EVD placement, and that is also a field when augmented reality could be very useful.
Thank you. Any other questions from the board? Otherwise, we can move to the questions from the Q&A, which we have some. So the first one is from Lorenzo Civiglia. This is about that you mentioned various different devices, including HoloLens, and you showed results of these studies. And the question specifically is, are these studies based on HoloLens 2? And what is your opinion about HoloLens 2 and about Apple Vision Pro? Is there anything about the Apple Vision Pro?
Well, unfortunately, I don't know anything about Apple Vision Pro. And I don't think that there is basically a fundamental difference between different versions of HoloLens, or if you look at different versions of Magic Leap. What is important is how you align your radiological image with the patient. And that is not device dependent. That's the technology that you use for patient overlay that will determine that. Obviously, the modern HoloLens and the second version of the Magic Leap are much better regarding field of view and visualization and things like that. But when it's
your microphone just 5 seconds ago stopped.
Surgical accuracy, the version of the device is not important, but that's the overlay that is the important part.
So then you showed different studies and from different devices. And so how do you explain the difference in accuracy? For example, the HoloLens in general, I think, if I remember correctly, what you showed was a little tiny bit worse.
Yeah.
Is that due to different algorithms of matching of core registration, or is it so? It's you say it's not based on the hardware itself, like the
no,
light
it's the algorithm that you use for image registration to the patient. So if you look at the X-Vision, they have a rigid reference frame attached to the patient, the same way when we have used the BrainLab system with the Magic Leap. But if you use only QR code attached to the patient's face and try to overlay an image and use the HoloLens, then obviously you will have a little less accuracy. And that also depends on what are your requirements. If you are going to place an EVD, it doesn't matter if the accuracy is 3 or 4 millimeter off and you are trying to hit a large ventricle. But if you are going to do a tumor surgery and an intramedullary tumor, and you need basically exactly to know where it begins and ends, then 4 or 5 millimeters will matter quite a lot.
So it really depends on what you want to do. If you just want to visualize and imagine something, maybe you don't need super far developed way of corriging. If you want to place a pedicle screw in the cervical spine, then you
exactly. So you know, if you want to resect a temporal glioblastoma and just want to position your patient in the correct position, then you can use this rough overlay and then use it when you position the head, and then you see, okay, now I can see all the part of the tumor and I can reach it, and that's okay. And then you remove your augmented reality and go on with your surgery. So that is the things that you can use augmented reality for, and you don't need to have them during whole surgery.
All right. And then another question is from Alan Forster, who says, thank you, nice talk. The question is about updating tracking, and you talked a little bit about that. And he says maybe more for brain tumor or DBS work rather than spine, but have you linked intraoperative neurophysiology findings to compensate for soft tissue shift? So do you, maybe you didn't do that, but do you know any studies about?
I have the privilege of being part of a Horizon 2022 project, which is called Stratum, together with University of Las Palmas, with our colleagues in Eindhoven. So this project actually tries to build a comprehensive surgical aid for the surgeon using all the information in the OR, including navigation, electrophysiology, and basically everything that you can get from the anesthesiology monitoring and preoperative and intraoperative different devices, hyperspectral cameras, ultrasound, intraoperative imaging. So there is a large European project going on. It is a 5-year project that basically just have started. And yes, we are going to work on this to integrate all these systems to give the surgeon immediate answer for the questions that we can ask during surgery. And the Stratum is basically aimed for cranial surgery.
All right, it's super interesting to integrate different kinds of inputs. Then we have a short question by Uri Hadelsberg. So you mentioned at the beginning a cheap, ready-to-use AI or augmented reality device, I guess. Which one was that?
I think those based on HoloLens are the most cost-effective ones right now. If you just want to try to augmented reality, that is the cheapest you can get.
All right, and then there's a specific question about sterilization of the device. So do you need to do anything about that?
No, you don't need to sterilize them. You need obviously to wear them. So either in the study that we did with the Magic Leap, the surgeon, you know, fits the headset and everything, and then you take him off. You go out, you wash your hands, come back, and then the assistant just puts it on your head and attaches the camera to the computer. So we have used it in a sterile environment, and it can be done with minimum disruption of the workflow.
All right. And then the last question is by Pablo. It's basically just saying that you did a nice talk. And I guess to summarize it, it's about the democratization of this technology. So do you see in the future that it could become so affordable and easy to implement in every operating room in the world that this can really globally be used? Or do you think that it's so do you think it's something for global neurosurgery, or will it remain something really special?
I think that augmented reality actually is a more global product than fancy, expensive navigation systems. So imagine that you are somewhere in Africa in a low resource setting, and you want to do a rather complicated procedure, and you need help, and then basically I could put on my HoloLens and you could put on your HoloLens. As far as we have an internet connection, then we could see the same image, and I could guide you through the procedure. And if you look at the prices for different devices. Obviously, okay, iPhones are getting more and more expensive, but on the other hand, many other devices are getting cheaper. So I think that a head-mounted display could be fair.
Your microphone just shut off. We made it quite a long time now, but
Which means that
yes.
we sure, yeah. And I think that then a head-up display could be an affordable device in many parts of the world. Obviously, it's not going to be for free, but they are going to get cheaper. And I think that the chances of globalization of these devices is much larger than expensive navigation systems.
Promising. Are there any questions from the panel? Otherwise, I have one little question that I was Nikolai? No, one question that I was wondering about. You showed some stuff with robotics.
Yeah.
You didn't really show a video or an actual implementation of that. So I found it kind of hard to imagine why, when you are using a robot, why would you then need augmented reality, or what is the interplay between the two technologies when you use them?
Very good question. The short answer is that robots are stupid. So what I use augmented reality for when I use a robot is to just make sure that it doesn't do anything stupid. So this will give me the information that, okay, the robot is proceeding according to the plan, and if it by any means deviates from the plan, I can immediately stop the procedure.
Okay, so it's really a safety backup.
Yeah.
Great. All right. If there's no more questions, I think we are ready to close the webinar. Maybe Nikolai, you want to say something?
Thank you, Victor, for this very interesting webinar. I think that the topic was of great importance and exactly in the field of EANS, which is great. Thank you very much for presenting this very, very interesting presentation. I just wanted to remind our auditorium that they can make a registration for the Congress of EANS that will be held in October in Sofia from the 13th till the 17th. Unfortunately, the early bid is already closed. It was until the 20th of June, but now we have a standard registration for 2 more months, so please proceed. I'm sure that we're going to have a great event here in Sofia, and you are more than welcome. Thank you.
So please join us live in Sofia and not via virtual reality or augmented reality. That's still best sometimes, live. All right. Thank you, everyone, especially Adrian and the panel for organizing this. And I think we're ready to close the webinar. Have a good evening, and we are just in time to watch the next football matches. Bye-bye.
Have a good day, everybody. Bye.